to the journal feed. My name's Nick Zelt, and this is the only place to be spoon fed the latest and greatest of emergency medicine. Our team combs through the literature for the best articles so that you don't have to, and provides expert summaries no bigger than a spoonful so that you can keep up with the ever changing landscape of acute care medicine. This is the audio version of the past week summaries brought to you by the brilliant Sam Parnell, Bo Stubblefield, and Clay Smith. The first article was titled Plaster Cast versus Functional Brace for Non-Surgical Treatment of Achilles Tendon Rupture, a multi-center randomized controlled trial and economic evaluation out of the Lancet. Not all Achilles tendon ruptures need to be operated on, and non-operative treatment is an option with equal outcomes. Non-surgical patients are usually put in a cast for 8 weeks, and casts are great because they offer maximum protection to the tendon. But this comes at the cost of being non weight bearing, which contributes to muscle atrophy, ankle stiffness, and a potential risk of DVTs. So that begs the question, would a functional brace do as well? This was an unblinded multi-center RCT called the UK STAR with 540 patients who had Achilles tendon ruptures and chose a non operative approach. Patients were randomized to either a plaster cast with a slight plantar flexion or a functional weight bearing brace. The cast was successively altered to allow less and less plantar flexion over 8 weeks, and only at 6 weeks was weight bearing allowed. The brace was a removable walking boot with wedges to lift the heel and relax the Achilles tendon. The braced patients were allowed to weight bear from the start and had wedges removed over the 8 weeks until the foot was perpendicular with the floor and then the boot was removed. All patients had usual physiotherapy follow up after the 8 weeks, and minimal crossover was seen between the groups. At the 9-month time point, between the groups, there was no difference in the primary outcome of Achilles tendon rupture score, and adverse outcomes were statistically equal between the groups, with adverse outcomes including things like tendon re-rupture, DVTs or pulmonary embolism, falls, heel pain, or numbness, and pressure scores. On top of that, the total cost for bracing and for casting was similar between the two groups. I think I know which one I'd want. Getting to walk and be able to remove the boot to take a shower, that would make a big difference. So, in a spoonful, a walking boot versus rigid cast resulted in equal outcomes and adverse events, including tendon re-rupture at 9 months for patients with Achilles tendon ruptures. The next article was titled Management of Toddler's Fractures, a Systematic Review out of the Pediatric Journal for Emergency Medicine. The traditional treatment for a toddler's fracture, or a suspected one, is an above the knee cast. But this isn't often actually done in practice. The largest study of toddlers' fractures showed that a controlled ankle motion boot, a cam boot, is adequate and allows earlier weight bearing. All the kids from that study showed good healing and return to weight bearing in 4 weeks, regardless of treatment modality. So, do we need to do anything at all for toddlers' fractures? 6 retrospective studies and 1 survey were found for a systematic review. The authors could not conclusively recommend that non mobilization was safe based on this information. Though they did note that the majority of studies suggested that toddlers' fractures can be managed conservatively with either no initial mobilization or the use of a cam boot. It's important to note that casting isn't benign. Skin breakdown is common in children immobilized with a cast and is seen in an estimate of 3 to 26% from this data. In a spoonful, this study was inconclusive, but it provides assurance that treating children with confirmed or suspected toddlers fractures in a cam boot is safe and equally effective to casting. All right, and the third article is titled Digital Technology Distraction for Acute Pain in Children, a meta analysis out of the Journal of Pediatrics. More and more, we are tempted when trying to do an anxiety provoking procedure to put a screen playing any myriad of entertaining videos in front of a child. Personally, I tend to favor Baby Shark. Infuriating as it might be, it works pretty consistently. But does this actually help to relax them and improve their tolerance to procedures? This was a meta analysis of a whopping 106 studies on the use of digital distractions during painful pediatric procedures. Methods included mobile phones, tablets, TV, DVD, laptop, virtual reality, essentially anything with some kind of screen to put in front of the kid has been tried. When combined, these techniques showed a clear improvement in patient rated, observer rated, and behavioral rated pain and distress. For pain, there was 46 RCTs. Pulled together, these methods translated into a pain reduction of about 1 on the Wong-Baker Faces Pain Scale. For self-reported pain, there were 19 RCTs, pooled to show a drop in pain scores of 18 on a 100-point visual analog scale. Honestly, our author Clay agrees with this. This makes sense. And even in my own relatively conservative experience, this makes sense. A screen can work miracles on some kids, and a tiny bit of screen time is not something I would consider harmful. In a spoonful, the use of digital distraction, really from anything with a screen on it, was effective in reducing pain and distress in the pediatric population undergoing painful procedures. The next article is titled Western Trauma Association Critical Decisions in Trauma: Cervical Spine Clearance in Trauma Patients, out of the Journal for Trauma Acute Care Surgery. Cervical spine injuries are uncommon, but when they do occur, they are potentially devastating for trauma patients. The Western Trauma Association, WTA, has recently published an algorithm to help with the approach to these patients. Already, for these patients, we've come to know and love the Nexus and Canadian C spine criteria to help us figure out when to image. The WTA aims to go beyond that, beyond just the choice to image, with an expanded algorithm for cervical spine management, aiming to minimize unnecessary imaging without increasing the risk of missing clinically relevant injuries, and to get our patients off of spine motion restriction and out of rigid collars when it's appropriate. The recommendations here were based on published prospective and retrospective cohort data, as well as expert opinion from WTA members. Of course, no algorithm will ever completely replace bedside clinical judgment, though. As a visual tool, the best thing to do will be to take a look at the algorithm yourself, either on our website or from the original journal article, but we'll take a quick walk through the major points. So, you have a patient arriving with a cervical collar and on spinal precautions, assuming you've already handled your ABCs, primary assessment, and all that. You're now concerning yourself with their cervical spine. The first step is to consider the patient as a whole. You're looking for anything that might prevent them from communicating to you that they're injured. A normal patient would have a normal mental status, not intoxicated, no language barrier, and no distracting injury that would prevent a reliable physical exam. If your patient passes this test, then move on to physical exam. A normal patient would have a normal active range of motion, no midline cervical tenderness, no focal neurological deficit, and no spinal deformities. If a patient is all of these patients are now cleared. They may stop cervical precautions. But keep in mind that you might still consider scanning patients with high risk mechanisms of injury, those with comorbidities, or at the extremes of age. If your patient fails either of these two exams described, then you need a high resolution CT of the cervical spine. Patients who failed the initial examination. So, these are patients with abnormal mental status, intoxicated, a significant language barrier, or a distracting injury. These patients are receiving a screening neck CT. Screening because they don't yet have evidence to support a cervical injury, but we also lack reassurance of its normalcy. And if you get back a normal screening CT, it is sufficient to stop cervical spine precautions, even in an overweight patient or an intoxicated patient, since a high quality screening neck CT has a negative predictive value of nearly 100% for excluding unstable injuries. In contrast, patients with abnormal exams, so this is anyone of restricted range of motion, midline tenderness, focal neurological deficit, or spinal deformities, are receiving a diagnostic CT because we have clinical evidence to suspect a cervical spine injury. A normal diagnostic CT will still require an MRI of the spine, and only if that is negative for injury. Should the collar be removed and precautions stopped? If scan results come back positive for injury, the algorithm handles this also. But I won't belabor the findings too much here. In essence, any spinal fracture will require a spine consultation. If there's no fracture, but an abnormal MRI due to ligamental or spinal cord injury, then those with an abnormal exam should get a spinal consultation. And those without abnormal exam, i.e., those getting the screening CT, can have precautions discontinued. In a spoonful, the Western Trauma Association has published an algorithm for the approach to adult patients with potential cervical spine injuries. I would suggest that you take a look at the algorithm for yourself and perhaps consider using it when your next trauma patient rolls in. The last article is electrical versus pharmacological cardioversion for emergency department patients with acute atrial fibrillation, a partial factorial randomized trial out of the Lancet. Atrial fibrillation is the most common arrhythmia diagnosed in the ER. The management typically centers around the balance of rate versus rhythm control after you've considered the need for anticoagulation if there's a risk for thrombosis and stroke. Rhythm control is done with either pharmacological or electrical cardioversion, with significant practice variation for how to best cardiovert. And the RACE 7 trial raised the question of whether early cardioversion was needed at all. So since you have a few options of how to do this, what's best? Should we drug then shock or just shock? This was a randomized, blinded, placebo-controlled clinical trial of just about 400 patients with acute AFib across 11 centers in Canada, randomizing patients for attempted cardioversion with IV procainamide at 15 mg per kg over 30 minutes, followed by electrical cardioversion if necessary, or placebo infusion followed by electrical cardioversion. Additionally, for patients who received electrical cardioversion, there was also a randomized open-label nested comparison of anteroposterior versus anterolateral pad placement. Most patients were successfully cardioverted, at 96% in the drug then shock group and 92% in the shock only group, and then were discharged home 97% of the time and 95% of the time, with no statistical differences between the groups. 52% of patients in the drug then shock group converted after procainamide infusion alone, and no patients were observed to have serious adverse events at follow-up. Also, there was no significant difference in the rate of electrical cardioversion with anterolateral or anteroposterior pad placement. So, both strategies, drug shock and shock only, appear to be highly effective, quick, and safe methods for rhythm control in AFib. But with pharmacological cardioversion, approximately half of patients avoided the procedural sedation required for electrical cardioversion. So it seems like procainamide infusion may be a better initial choice for cardioversion, especially in first episodes and for patients younger than 70 years old. In a spoonful, there was no significant difference in overall rate of conversion from atrial fibrillation to normal sinus rhythm, with procainamide infusion followed by electrical cardioversion if needed, compared with placebo infusion followed by electrical cardioversion. So, what did we learn today? We learned that casting may not be needed for Achilles tendon ruptures, and that you can consider using a walking boot for early mobilization. Studies were inconclusive if it's safe not to treat toddlers' fractures at all, but for now, a cam boot is safe and as effective as casting. Next, if you have to do something painful on a child, you're justified in putting a screen in front of them. It helps. Then, the Western Trauma Association has released an algorithm for cervical spine precautions. And finally, about half of patients can avoid electrical cardioversion for AFib with a procainamide infusion. But overall rhythm control rates are not changed by the addition of pharmacological rhythm control to electrical cardioversion. That's it for this week, guys. Links to all the articles summarized can be found at journalfeed.org, where if you haven't already, you can subscribe to our newsletter and get daily spoon feeds through your email. If you like Journal Feed and you like the podcast, feel free to show us some love. Head over to iTunes, give us a rating and a review. We'd love to hear from you. Here at the Journal Feed, we like to keep up with the latest research, and we want to help you do the same, one spoonful at a time.